So anyone interested for skill session, that is anastomotic leg examination, can you raise your voice so that I can understand, or raise your hand? Just participate. I can help. I can help.
Yes, I would like to do. So,
Yes. Yes.
Sonia this side.
Sonia. Okay. Okay. Nice. Nice. Can you please introduce yourself a little bit?
Hi, I'm Sonia. I'm from India. I'm giving my MRCS Part B on 16th of October in UK, in Edinburgh.
Okay. Thank you so much. So I'm going to put a timer for you and
Okay.
show you a scenario, and then you should perform. Like performance means you have to describe each and every point, like enter the examination station, what you have to do. You should verbalize each and every point. I'll help.
Okay.
No. Okay.
Sound
Okay.
session rounds.
Can other candidate please mute your mic so that I can communicate with Sonia? Okay. MS, can you please mute your mic?
Oh, sure.
Okay. So now I'm going to start the timer.
Okay.
Can you able to see the timer?
Yes, timer is visible.
Okay. So I'm going to share my screen. Can you able to see the screen?
Yes. Yes, screen is
The scenario?
visible.
Yeah.
Yes. So you are a surgical SHO to attend a patient presented with shortness of breath, generalized abdominal pain, left shoulder tip pain, and a scar covering the lower midline of the abdomen with dressing. Please examine the patient. It's important to remember that this is a clinical examination station. Please try to focus on examination rather than talking with the patient unless necessary. Okay, I'm ready.
You're ready? Okay. Okay, let's start.
Okay, I will enter inside the examination room and I will wash my hands with the help of gel, and I will say hello. I'm Dr. Sonia. I'm one of the surgical SHO.
Okay.
And how is patient reacting?
Okay, patient lying in the bed wearing a hospital gown. After exposing chest, abdomen, and lower limb, you notice a lower midline abdominal dressing, and patient had TEDS, that is thromboembolic deterrent stocking, and patient have short breath. Okay. Saturation is 80% with 2 liters of oxygen by nasal cannula.
Is patient talking? I will talk with the patient. Hello, Mr. X, how are you?
Yes, I'm not feeling good, doctor.
Okay, patient is talking. It means airway is quite patent, but still I will administer high flow oxygen at the rate of 12 to 15 ml, 15 liter per minute with humidified reservoir bag. Then I will look. Then I will start with the look, listen, feel, and so first with look. I will start with the from mouth around the lips, any central cyanosis. Then any accessory muscle movement like sternocleidomastoid movement or any chest excessive movement. And I will also calculate respiratory rate, and I will check for any depth of respiration, how patient is respiring. And then I will start with the feeling. For feel, I will check for the, I will keep my both hands on the chest of the patient, and I will check for the chest movement, whether equal or bilateral equal or not, any paradoxical respiration. And I will also check position of the trachea. And in neck, I will check for any raised jugular veins. Then I will listen with the help of my stethoscope anteriorly in axilla and posteriorly. Is patient able to sit? I will ask.
No.
Then I will auscultate only on the anterior side and the axilla. Is the patient having equal bilateral air entry?
Yes, equal.
Okay. Then I have already sorted my airway, and now breathing is also I've checked breathing, and I will percuss patient chest anteriorly. Is there any abnormal finding I'm
No,
getting?
chest movement is equal.
Equal. Okay. Then I will move to the circulation part. In circulation, I will check for pulse.
Before
Uh,
circulation, do you want to do any investigation, bedside investigation for breathing?
yes, I will ask for pulse rate. Sorry, oxygen saturation, and also for any chest X-ray. I would like to
Okay.
ask for chest X-ray, and then I will go for the circulation part. In circulation part, I will check for pulse, radial and radial and central pulse, and also check for any rate. How is the pulse rate of the patient?
Mhm. Rate is 120 beats per minute.
Okay, 120. And what is? And then I will check for blood pressure. How is blood pressure of the patient?
So blood pressure is 100/70.
Okay, 100 over 70. Okay. I will ask my assistant or any nurse who is available with me to apply the two white bore cannulas and start the Hartmann solution because patient is in hypovolemia. And then after that, I will also check for capillary refill time after pulse rate, and I will auscultate the heart. Then I will go towards the, I will ask for ECG leads also in this patient. Then I will go for the D portion, that is the dysfunction and the CNS portion. And according to AVPU system, I will check patient alert because my patient was talking with me. Means patient is alert, and but again I will check according to AVPU what is the finding of my patient? Is patient responding to verbal stimulus?
Yes, responding.
Okay. Patient is responding, and after that, I will this one, and then after AVPU, I will expose the patient in the presence of Chevron, and I will remove the dressing. How is the dressing? How is the wound?
Dressing is the wound is dry, but
Uh,
tender.
Okay. Patient is having tenderness over the wound, over the abdomen when I started examining the abdomen. So I will now in the after exposing and after looking at the dressing portion, now I would like to I will superficially do the abdominal examination, and I will try to be as much as gentle and away from the painful point. And if patient would be able to bear with the pain, I would also like to do the this.
No, it's
Uh,
non-bearable pain.
it's
It's so painful. So
oh,
painful.
okay. If it's a non-bearable pain, I won't touch, and I will apologize for to the patient that I'm really sorry I did that, and then I will check. My patient is already having TED stockings, but still, I would like to squeeze the calf of the patient to rule out the any DVT and pulmonary embolism, and also I would like to check the charts in which I will check new score and
In your
drug chart.
chart, in your chart, there is rising temperature, raising pulse rate, increase oxygen requirement. And in full blood count, there is leukocytosis and ECG, atrial fibrillation.
Atrial fibrillation. So atrial fibrillation, most probably it will be because of uh, it will be because of the sepsis. I would like to present my case.
Okay, thank you so much. Can you please present your case?
Yes, my patient presented with shortness, a pain abdomen, and I was called in the ward for this patient, and this patient is a post-op day. I forgot to ask post-op patient, and this patient was not hemodynamically stable. My patient was having hypovolemia, and also he was slightly breathless, and his pulse rate was around 110. And patient improved after high flow oxygen, and abdomen was tender, and according to me, my initial diagnosis is there is a anastomotic leakage. So I would like to re-explore the patient.
Okay. Do you have any differential diagnosis for this case?
In this patient, differentials can be um, anastomotic leak or any bleeding or sepsis inside in abdomen, and maybe some necrotizing fasciitis. No,
Okay.
not necrotizing fasciitis. I'm sorry, I used a wrong term.
How do you manage this case?
To manage this case, as already have managed this patient according to care of critically ill surgical patient, and I would like to treat this patient after CRISP protocols. I would like to take this patient. I will inform my consultant, and I will involve the multidisciplinary team approach, involve theater and anesthetist, and we will try to take this patient immediately for this for surgery, for re-exploration in OT.
Okay. What are the imaging you can suggest for this patient?
For this patient, we would like to take abdominal X-ray, erect supine, and also ultrasound and ultrasonography, and fast scan if available in the ward.
Okay. So if the patient required laparotomy, what types of procedure do you want to proceed for this patient?
Sorry, I could not hear you. Efficient report.
If the patient needs surgical intervention, what types of intervention would you suggest for this patient?
For this patient, exploratory laparotomy would be the best thing because patient is already operated, and patient might be having some anastomotic leakage.
Okay, your time already finished, but I'm going to ask you a few more questions. How do you differentiate between anastomotic leak and pulmonary embolism?
For anastomotic leakage and pulmonary embolism, I would start with the first with the post-op day. This anastomotic leakage will present on the post-op day 6, and pulmonary embolism most probably on the post-op day 8 or after. Then pulmonary embolism patient will present with chest pain, and anastomotic leakage patient will be with shortness of breath, or this, for example, in this stem they have mentioned left shoulder tip pain, means some perforation peritonitis like symptoms will be there. And in anastomotic leak, I will look around the patient, and patient will be wearing TED stockings, and pulmonary embolism case TED stockings won't be there. And in charts also, in pulmonary embolism, I will check for about the low molecular weight heparin given or not. And in anastomotic leak, in both of them, in some charts will also suggest something. Oxygen demand will be increased.
Tell me 3 investigations that suggest the differentiation between pulmonary embolism and anastomotic leak.
For pulmonary embolism, I would like to do chest X-ray, D-dimer, and also CTPA to exclude the pulmonary embolism, and also ABG. In pulmonary embolism, ABG will denote towards the respiratory alkalosis, and ABG of anastomotic leak will show metabolic acidosis.
Thank you so much for
and also ECG findings. I'm sorry, that will show AF, and pulmonary embolism will show different ECG findings.
Thank you so much for your participation, participation.
Thank you.
You did.
I want to add something. I forgot to take consent from them. Means I am verbal consent, and I forgot to inform patient that I'm going to examine him.
Okay, no problem. Let me explain. Let me explain this session.
Thank you.
So, no problem. So this is the post-operative anastomotic leak is Scripps station. But when you enter the station, first of all, read the instruction before enter the station. Read the instruction carefully. don't go blindly, because nowadays there's a common scenario, but they may change the scenario first of all. So if it is abdominal examination, you should enter the station, wash your hand, that is wafer, wash your hand, introduce yourself, then consent, then start abdominal examination, the typical abdominal examination like peripheral abdominal, hand, mouth, face, tummy. When he can't tolerate the pain, then you should proceed the cribs, unless you have lots of breathing difficulties or other things. Okay, so always remember, all post-operative case, most of the post-operative case are cribs protocol. No pre-operative case are cribs. So it's the general rules or general conception. So the next thing is you proceed directly for airway, breathing, circulation. But before that, you should examine the abdomen first and then go for cribs, because you went there to examine abdomen, but you find that the patient condition is not good at all. That's why you proceed the C-cribs protocol. The second thing is the patient was talking, so his airway is pattern. You see the look, listen, feel. That's really good. That's really good protocol to examine the patient. And in breathing, when you saw that the patient is on 80% 2-liter nasal cannula, so immediately you change the marks and oxygen. But did you check the pulse oximeter about his saturation, oxygen saturation at that time?
No, I forgot that.
Okay, so this is the first point. Secondly, then you should advise EEG, because you have to check the patient blood oxygen level. So there's the bedside investigation for breathing, 2 bedside investigation for breathing. Always remember chest X-ray and ABG, arterial blood gas analysis. So in breathing portion, you check any central cyanosis, chest wall movement, palpate chest expansion, percussion, auscultation. Did you check the position of trachea?
Yes, I informed that I will check the
Okay.
position of the trachea and JVP.
Okay, that's for breathings. Just remember bedside investigation. If the asks, you should remember the chest X-ray and ABG with the bedside investigation for B portion. And in C, start from finger. You can the capillary fill time, peripheral coldness, pulse. Then you should not check BP because it's time consuming, and you have already draft chart and observation chart there. So in observation chart, you'll find the blood pressure, pulse, and all information. And if there's nurse helping assistant, you can ask for blood pressure. Okay, so you should not go for blood pressure checking. That's one point. And then come this point, JBP, any dehydration, like shrunken eyes or something like that, and chest. Obviously, you should check in circulation, muffled heart sound or heart sound.
Yes, I forgot. I just mentioned that I will auscultate the heart.
Okay, that's good. And then in circulation point, the bedside investigation should be ECG. ECG. But in circulatory part, when you are in circulatory part for a breathlessness patient or a sepsis condition patient, you should follow the sepsis guideline. Like you should send blood sets of investigation. What are the sets of investigation? Is the full blood count, uroelectrolyte, LFT, CRP.
Kidney function test, CRP, yes.
Okay. So remember always full blood count, uroelectrolyte, LFT, CRP. And you already sent ABG, so that's not important. And lactate, obviously lactate, and culture, blood culture. So 5 or 6 investigation you should remember in circulation. You should introduce a wide bore cannula to draw blood for full blood count, uroelectrolyte, LFT, CRP, lactate, blood culture. Okay, these are the investigation you should send. And if any emergency need for blood, like blood grouping and cross matching, don't forget that. And then you should introduce crystalloid first take the blood and then introduce the crystalloid, and then continuously monitoring of the patient, because you introduce crystalloid and you should check blood pressure pulse for this patient. So you should organize this sentence. So I should introduce a white bore cannula for this patient and should like to send the sets of blood like full blood count, electrolyte, LFT, CRP, lactate, as well as blood culture for this patient. And like to introduce crystalloid, 500 ml bolus for 30 minutes. But it's according to guideline or scenario. Okay. And then bedside investigation, I told you that ECG. Okay, this part is for circulation. And in disability, you check the patient is alert, that's fine. In exposure part, always remember, you should check three things, three important things. What are the three important things? The three important things are, you should check the bandage area, I mean, the scar with dressing. So tell the examiner, I'd like to check the scar. Then examiner should say, okay, proceed. No risk with this scar and anything. So should proceed, first of all. Secondly, did you check the urinary catheterization? Any catheter for you?
No, I forgot. Yes.
You should check.
Yes, I forgot. Okay.
If no urinary catheterization, you should introduce urinary catheter for this patient. Okay. Then never compress, squeeze the cups for DVT and P. You should inspect the leg first. If it is swollen, discoloration, that's the first point. Second point is touch and look at the face, if this is tender or not. If this is tender, should not proceed for compression.
Okay.
Understand? So this is the exposure part. And then you should go for charts. So then when you finish that exposure part, then you should say, I'd like to check observation chart as well as drug chart for this patient. Why drug chart is important here? So drug chart is important here because for pulmonary embolism, sometimes patient miss anticoagulant. That's the first point. And this case, for observation charts, the rising temperature, rising pulse rate, decreased BP, increased oxygen requirement, and full blood count, you can see the leukocytosis, the atrial fibrillation. So there's the important part for charts, drug chart.
Okay.
Important thing, because last 3 minutes, you can't summarize everything, just main focus things, because for within 3 minutes, you have to summarize, you have to do differential diagnosis, you have to do management and some cross question also. So you should summarize within 30 seconds. Try to practice summarization within 30 seconds. Main important point and 1 or 2 negative points. That's all. Okay. And then for management, you should say nil by mouth, NG tube suction for bowel rest, urine catheter, monitor urine output, and may refer the patient to HDU central line or monitoring, fluid resuscitation by crystalloid, IV antibiotics, and sets of blood, what I mentioned. And the imaging test, important imaging test for this patient, chest X-ray, first of all. Secondly, you can do one abdominal ultrasound to detect any abdominal collection, CTPA to rule out pulmonary embolism, CT gastrography. Did you mention the CT gastrography in anemia to identify anastomotic?
No.
So that's the most important investigation for this case because it's the anastomotic leak case. So you should mention CT with gastrography in anemia to identify the leak is anastomosis. Understand?
Okay. Yes, sure.
Okay. So the patient will need urgent laparotomy. So the procedure name is Hartmann procedure with good peritoneal toileting plus drainage. So remember the line, Hartmann procedure with good peritoneal toileting, drainage. Understand?
Yes, sure. And
how do you differentiate between pulmonary embolism? You mentioned quite good. So the gold standard investigation is CTPA. That's fine. But in pulmonary embolism, patient may present with long bone fracture or road traffic accident or missing anticoagulation. Chest X-ray is normal and a change in ECG change in CTPA, there's the typical feature, or maybe miss anticoagulation. And in the anastomotic leak cases, you get post-operative history, tenderness abdomen, leukocytosis, and other things found. Do you understand?
Yes, yes, sure. Thank you, doctor.
Understand your lackings or what point you should improve? Or
Ye-
I think you did quite good. I just add some things, just some add-ons of.
Yes, sure, sure. Thank you very much.
No problem. So
Excuse
hopefully,
me. Hello.
yes.
So Reza,
Yeah.
I want to ask some question about this CRIPS protocol.
Yeah.
When we do the examination during this CRIPS, as it is important that I on that time I have to instruct the nurse also by the side of the examination.
No, actually, it depends upon scenarios. Sometimes scenarios say you are on call SHO, called by one nurse, and you should first introduce yourself to with nurse that I am on call SHO. I want to see the patient. Can you please show me the drug chart, off chart, or the patient information? Then you should check the patient identity, and then you should proceed. It depends upon scenario, but the typical scenario said there should be no nurse inside the station. That's the typical scenario. But always remember, you should read the scenario. So what scenario said, you should proceed according to that. Don't go blindly like previous recall. They may recommend some things like the same thing. You should not go. So read the scenario. What scenario said, you should proceed like that.
If the scenario is take me to the scenario like this, like there is an anastomotic leakage due to some abdominal operation. After that, the patient going to severely shortness of breath and abdominal pain. And at that time, I just entered the room and wash my hand and introduce myself and just go for the examination, but without any comment to the attendants or staff nurse. Right?
There should not be any attendant inside the room.
Inside
the examiner and nurse, maybe nurse, but nowadays there are no nurse in the station. So you should proceed or introduce yourself with the patient if there is no nurse. But if there's nurse, the scenario said you call by nurse. So you should introduce first with the nurse. I'm surgical SHO, on-call SHO. I would like to examine this patient, or I'd like to see this patient. Can you please show his or her drug chart or off chart or any chart, or should I proceed with this like this?
On the time during the time of the breathing or airway, saying that during the airway, is the patient is talking with us, there's the airway pattern, right? So during that time, if I used to give the patient a high flow oxygen or something during my examination, is there any action need to do during that checking of the airway?
Listen, this station, your performance time is 6 minutes, isn't it? The performance time is 6 minutes. So within 6 minutes, you have to perform lots of things. So if the patient is talking, you should stop checking the airway, because you don't have enough time to check each and everything, each and every point within 6 minutes. So if the patient is talking, that is airway pattern. That's all. This is not the station for airway management. This is the CRIPS management. So then stop. I can proceed for airway, look, listen, feel, and lots of things inside the mouth. But you should follow some strategy. So spend lots of time in airway. So my patient is talking, that is airway pattern. And then go to breathing section. So make sure patient is with proper nasal cannula or face masks or rebreather masks or any masks, and check the saturation. Then check the ABG also.
Thank you for your cooperation.
No problem. Thank you for your participation. You did quite good today. MS, Dr. MS, can you hear me? Sonia.
Yes, I can hear you.
Do you understand the CRIPS protocol and these things, what I say?
Yes, doctor.
Okay. If you have any confusion, further confusion, don't hesitate to put your message in our chat box or in our group. Okay.
Sure, sure.
So tomorrow we have one important session for communication as well as history taking. But we'll take by one of my colleague. He's on surgical training, Wells. Hopefully that will be a wonderful session. You should join with him tomorrow,
Sure.
5 p.m. Okay.
Okay, sure.
Thank you
Thank
so
you very
much.
much. Have a good day.
Have a good day. So I have to close this session for today. If you have any confusion, let me know. Bye.
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 Thank you, sir.
No problem.